So here's the abdomen. Abdomen we are starting here. Then rectus sheath. Rectus, it's an aponeurotic sheath covering the rectus abdominis muscle. So it's the muscle which it covers. The rectus sheath covers the rectus abdominis muscle, and it's an aponeurotic sheath. It has two parts, anterior and posterior. Rectus sheath has two parts. For features, anterior wall, it is complete covering this muscle from end to end. It is composition. Its composition is variable as described. It's firmly adherent to the tendinous intersections of the rectus muscle. So posterior wall, it is incomplete, being deficient above the costal margin and below the arcuate line. So there's one thing that in the rectus sheath, it's an aponeurotic sheath, and we have an anterior and a posterior wall, and the anterior wall is complete while the posterior wall is incomplete, being deficient above the costal margin and below the arcuate line. So we know that the costal margin is there, which is surrounding the ribs. So above the costal margin it is deficient, and below the arcuate line it is deficient. Its composition is variable as described below. Formation: above the costal margin, anterior wall is formed by external oblique aponeurosis. It is posterior wall is deficient. The rectus muscle rests directly on 5th, 6th and 7th costal cartilage. So above the costal cartilage we have external oblique aponeurosis, and the posterior wall is formed by 5th, 6th and 7th costal cartilage. Between the costal margin and arcuate line, external oblique aponeurosis and anterior aponeurosis of the internal oblique. So there's external oblique aponeurosis and anterior aponeurosis of internal oblique. Posterior lamina of aponeurosis of internal oblique and aponeurosis of transversus muscle. So the anterior wall from costal cartilage and arcuate line, in between this, the anterior wall is formed by the external oblique aponeurosis and internal oblique aponeurosis. Its anterior part, anterior lamina, and the posterior wall is formed by the posterior lamina of the aponeurosis of internal oblique muscle and the aponeurosis of transversus muscle. So these both forms. Below the arcuate line, aponeurosis of all three flat muscles of the abdomen. Aponeurosis of the transversus, internal oblique are fused, but the external oblique aponeurosis remains separate. And here posterior wall, it is deficient rectus muscle, fissure transversalis. Posterior wall, it is deficient here, rectus muscle, fissure transversalis. Now content, only in the posterior only fissure transversalis is present. Content, we know content, there is two muscle, rectus, there is a rule of two. Okay, here everything is two. Muscles are rectus abdominis and pyramidalis. Artery superior epigastric, inferior epigastric. Superior epigastric enters sheath by passing between the costal and xiphoid process. Inferior epigastric enters sheath by in front of the arcuate line, it enters the sheath. And nerve, superior epigastric vein, superior epigastric vein and inferior epigastric vein, nerves, terminal part of lower 6 thoracic nerves. Function: check bowing of the rectus muscle during contraction, maintain strength of anterior abdominal wall. So when we bend, at the time when we bend, then there is the tendency that the rectus abdominis muscle may move. Means it is normal tendency that if you are bending, then the muscles will sag. So during contraction, it checks the bowing of the rectus muscle. It keeps the muscle in its place. When we are bowing, at that time also muscle is in the place. It will not sag. So this is the thing, maintain strength of the anterior abdominal wall. So rectus sheath we are here. The diagram is not given in this. The diagram we should see from the book itself. So it's an aponeurotic sheath covering the rectus abdominis. It has two parts, anterior and posterior. There are two parts. There are two walls, and this is anterior wall is complete, covering the muscle from end to end. Its composition is variable. We will discuss, and it's firmly adherent to the tendinous intersection of the rectus muscle. We seen this when the rectus muscle have many intersections. At that intersection, this is firmly adherent, but someday and other ways it is not that firmly adherent. एंड पोस्टीरियर वॉल इट इज़ इनकम्प्लीट एंड डिफरेंट डेफिशिएंट होती है कॉस्टल मार्जिन के ऊपर भी और जो हमने आर्कुएट लाइन है उसके नीचे भी. और इसका कंपोजिशन देख लिया. कॉस्टल लाइन के ऊपर जो एंटीरियर वॉल है वो फॉर्म हो रही थी अपनी एक्सटर्नल ओब्लिक एपोन्यूरोसिस से. एक्सटर्नल ओब्लिक एपोन्यूरोसिस इज द आउटर मोस्ट लेयर. इट्स द आउटर मोस्ट एंड द फीशर ट्रांसवर्सालिस इट इज़ द इनर मोस्ट. इट इज़ द फीशर ऑफ द ट्रांसवर्सस मसल. So this is the thing. Composition is variable as described below. We seen that above the costal margin, anterior wall external oblique aponeurosis से, posterior wall deficient है. It rests directly on 5th, 6th and 7th rib, costal cartilage. Then we have between that we have external oblique aponeurosis and the anterior aponeurosis of internal oblique. Internal oblique का जो anterior lamina है वो internal oblique का posterior lamina, और जो इक्वल मसल है अपनी वो है ट्रांसवर्स मसल, वो उस दोनों मिलकर posterior wall बनाएंगी. और arcuate line के नीचे aponeurosis of all three flat muscles of the abdomen, aponeurosis of the transversus and internal oblique are fused जो इंटरनल ओब्लिक और ट्रांसवर्सस मसल है, इन दोनों का तो एपिड्यूरसिस एक साथ होता है, और जो एक्सटर्नल ओब्लिक वाली है वो अलग रहती है, सेपरेट ही रहेगी वो. और पोस्टीरियर वॉल इट इज डेफिशिएंट रेक्टस मसल फीशर ट्रांसवर्सालिस में. कंटेंट हमने देख लिया, 2 मसल है, 2 आर्टरी है, 2 वेन है, 2 नर्व्स है. नर्व्स टर्मिनल पार्ट ऑफ लोअर 6 थोरेसिक नर्व्स. इसको मत भूल जाना, नर्व्स में जो लोअर 6 थोरेसिक नर्व है ना, 12, 11, 10, 9, 8 and 7. So from 7 to 12 the thoracic nerves, these are all part of this and function we have seen. Now inguinal canal, oblique intermuscular passage in the lower part of the anterior abdominal wall. See, if this diagram here is not present, what? Yes, here it's here. So inguinal canal is this thing, right? So it is present obliquely in the anterior abdominal wall. It's present obliquely. This is the inguinal canal, and there is inguinal hernia also, which can be protruded in this inguinal canal. So we study this. Inguinal canal is an oblique intermuscular muscular passage in the lower part of the anterior abdominal wall, situated just above the medial half of the inguinal ligament. Inguinal ligament का जो medial half है उसके just ऊपर होता है. हमारे पास जो हमारा inguinal ligament होता है उसके medial half के just ऊपर, इसमें अभी इसमें डायग्राम में नहीं है, जो हमारा इंग्वाइनल लिगामेंट चल रहा होगा उसके जो मिडिल हाफ है उसके जस्ट ऊपर होगा, जस्ट अबोव, इट्स लाइक 1.25 सेंटीमीटर अबोव. इट्स डायरेक्टेड डाउनवर्ड, फॉरवर्ड एंड मीडियल. इट्स दिस इंग्वाइनल कैनाल इज डायरेक्टेड इन दिस वे, इट्स डाउनवर्ड, फॉरवर्ड एंड मीडियल. Situated extend from the deep inguinal ring to super. So there's superficial and deep inguinal ring. In between these two, the inguinal canal extends. Deep inguinal ring, now we will learn about it. Means deep inguinal ring is come, and here is the superficial inguinal ring. Deep inguinal ring has oval opening in the fascia transversalis. In the fascia transversalis, the deep inguinal ring opening is there, situated 1 centimeter, 1.2 centimeter above the mid-inguinal point and immediately lateral to the stem of the inferior epigastric artery. It's just immediately lateral to the stem of the inferior epigastric artery. This is important, you remember this, that is present just lateral to the stem of the inferior epigastric artery. Now the triangular superior inguinal ring, it's triangular opening. We know that here when it will open, then it's like somewhat triangular opening, and the base is formed by the pubic crest, which will be here with the bone which is present here. It will form the base of it, and it has this base is formed, but the triangle will have these two. These are the two cruras. एंड लेटरल मीडियल मार्जिन्स जो ट्राइंगल की है ना, उनको हमने यहाँ पे क्रूरा बोला है. लेटरल मीडियल रेफर्ड एज क्रूरा. ट्राइंगुलर ओपनिंग है इन एक्सटर्नल ऑब्लिक एपिन्यूरस. इट्स लाइक एन ऑब्ट्यूज एंगल ट्राइंगल. ऑब्ट्यूज एंगल ट्राइंगल इज व्हाट? इट हैज this type of triangle. This base is formed by the pubic crest of hip bone, and these two are the lamina, which are also called the crura, or two margins of triangle with lateral medial referred as crura. Beyond the apex of triangle, two crura united by intercrural fibers. So these two cruras, these are united by intercrural fibers. So superior inguinal ring, triangular opening in external oblique epinurosis. It is like an obtuse angle triangle. The base we saw, this margins and all this is all same. In deep inguinal ring, you remember that this is 1.25 centimeter above the mid inguinal point. The mid inguinal point, it's above. In this what here we said that inguinal canal is situated just above the medial half of the inguinal ligament. So inguinal, we have full inguinal ligament. So its medial half. The medial half of inguinal ligament, just above it, this this inguinal ring is situated just above the medial half, and this superficial deep inguinal ring is it's situated 1.2 centimeter above the mid inguinal point. Here it is. Now superior inguinal ring, deep inguinal ring, we have studied this. What's that kind of opening? It's oval, this is triangular. How it's 1.25 centimeter above the middle inguinal point, and it's opening in fascia transversalis. This is also important, that it's opening in fascia transversalis, and it's opening in external oblique epinurosis. It is the most innermost layer, it's the most externalmost layer. So you remember this, okay? So deep, so you can learn that deep will be in the most innermost, and this is superior, is superficial, then it will be in the most superficial layer. It's like an obtuse angle triangle. This all the boundaries are there. Anterior wall, so we have this ring, and its ring we have its boundaries. Anterior wall who forms, posterior wall who forms, then its medial wall who forms, then its lateral who forms. So these are all things. In anterior wall, whole extent, so we know the skin and superficial fascia will be present. Okay, this is done. External oblique epinurosis is present in whole extent. External oblique epinurosis will be present in whole extent. Lateral 1/3 we have internal oblique muscle. This Internal oblique muscle is present in the lateral one third only. In the lateral one third only it is present. In the whole extent we have external oblique aponeurosis, but in lateral one third only we have this muscle, that is the internal oblique muscle. In the posterior whole extent we have fascia transversalis, extraparietal tissue, parietal. These things are just present in the back side. Means fascia transversalis is present, then behind it is extraperitoneal tissue, then behind it is peritoneal, peritoneum. These all things are present in the posterior wall. In the posterior wall whole extent we have fascia transversalis, extraperitoneal tissue, parietal, peritoneum. But in the middle two third, here we have lateral one third. In the middle two third we have conjoint tendon. Conjoint tendon are formed by the external oblique, internal oblique. We saw that in the transversus muscle plus the internal oblique muscle, these both form a conjoint tendon, that is form a tendon together, that is called the conjoint tendon, while the external oblique muscle, it remains separate. External oblique muscle is a separate muscle. So roof arched fibers. Okay, so we were here. Middle two third is covered by conjoint tendon. Posterior wall middle two third is covered by conjoint tendon. Middle end by a reflected part of the inguinal ligament. Roof arched fiber, internal oblique, transverse abdominis muscle. Ground grooved upper surface by inguinal ligament, medial end by lacunar ligament. Sex difference: inguinal canal is larger in male and smaller in female. So this is the reason why the inguinal hernia are more common in the males. This is the most common. This is the reason, because the inguinal canal is larger in male than in female. So here we saw in the anterior wall, we saw in the posterior wall, we saw. So you just think one thing: in the anterior wall we know the outer structures will lay like external oblique aponeurosis. In the posterior wall there will be inner structure like fascia transversalis, and in the lateral to one third there is internal oblique aponeurosis. In the middle two third there will be conjoint tendon will be present there, middle end of the reflected part of the inguinal ligament, because inguinal ligament is also present just below to it. So there will be the middle end of the reflected part of inguinal ligament. So there is a middle end of reflective inguinal ligament. So the roof, in the roof we have arched fibers of internal oblique and transverse abdominis muscle. So the roof which is formed, the roof will be present above this. The roof will be present above this, and it's formed by the arched fibers of internal oblique and transverse abdominis muscle. Internal oblique and transverse abdominis muscle. So you can remember one thing, that in the posterior wall and in the roof both are there internal oblique and transverse abdominis muscle, whether it may be in the middle two third part or in the whole part. The floor is grooved upper surface of inguinal ligament, middle end of by lacunar ligament. So we know that lacunar ligament is present, which is present just in the side of the our femoral canal. It is present. So the floor is formed by grooved upper surface of inguinal ligament and middle end by lacunar ligament. It's present. Sex difference: inguinal canal is larger in male and smaller in female. Structure passing through the canal is spermatic cord in males, round ligament. So there are two structure. There is spermatic cord in the males, and there is round ligament of uterus in the female. So this is the only difference you need to remember, that spermatic cord in male and round ligament of uterus in the females. So here it's done. Now we have ilioinguinal nerve enter the canal through the ilioinguinal nerve. We know this is L1 ilioinguinal and iliohypogastric. These are both L1 nerves. We have seen them before also. So now enter the canal through the interval between the external and internal oblique muscle, pass out through the superficial inguinal ring. So we know that one more nerve is the ilioinguinal nerve, which enters the canal through the interval between the external and internal oblique muscle and pass out through the superficial inguinal ring. That's it. Now we have spermatic cord. Spermatic cord is the content of the inguinal canal. Spermatic cord is the content of the inguinal canal. And now constituents of the spermatic cord. So you get to know this, that there are two things. There are inguinal canal and inguinal ligament. Inguinal ligament, we discussed it many times, that it starts from the anterior superior iliac spine, and it goes up to the pubic crest. It goes up to there. So this is called our inguinal ligament, and here we are talking about the inguinal canal. So inguinal canal is here, and the content of inguinal canal we studied. This is spermatic or round ligament of uterus in females, and we also have ilioinguinal nerves that enter the canal through the interval between the external and internal oblique muscle. And between the external and internal oblique muscle, it will enter the cord, and then it will pass through the superficial inguinal ring. Then that's it. Spermatic cord, we have constituents of spermatic cord. We have spermatic cord. Now spermatic cord itself is a content of inguinal canal. Now we are considering the structures which are present inside the spermatic cord. So constituents of spermatic cords: ductus deferens, testicular and trimestic arteries and ductus deferens arteries, pampiniform plexus of veins, lymph vessels, genital branch of genitofemoral nerve, plexus of sympathetic nerves, remains of processus vaginalis. So these are the constituents of spermatic cord: ductus deferens, testicular and cremasteric arteries and ductus deferens arteries, pampiniform plexus of veins, lymph vessels and genital branch of genitofemoral nerve and plexus of sympathetic nerves. So this is also remember all these things, that is ductus deferens, you remember these, because we know in the spermatic cord we have vas deferens which will be running in it, because this vas, we know here we have the diagram, because there is a vas deferens which will run in the spermatic cord and go in the inguinal ligament. So it is this type of movement, and then it will finally drain into the ureters, and then in the urethra, through the urethra it will come out. So this is the thing. Spermatic cord, we have ductus deferens, and we know that in the spermatic cord layers, we know that here is the cremasteric fascia, and there is also muscle here, there is a cremasteric muscle, so there will be the vessels which will supply here. So testicular and cremasteric arteries and ductus deferens arteries, we will have arteries will be forward, there will be arteries for the testis, because this is the only way to reach the testis through the spinal cord. So there will be arteries for the testis, there will be artery for the cremasteric muscles which is also present, and there will be artery for the ductus deferens which is running through it. So artery will be for all the three structures, that is testis, ductus deferens and cremasteric muscle. We also have pampiniform plexus of veins. We have vein, for veins we have pampiniform plexus. So in veins we have pampiniform plexus of veins, and lymph vessels, genital branch of genitofemoral nerve and plexus of sympathetic nerves. These veins are present in the spermatic cord, pampiniform plexus of veins. This is very important. In veins we have pampiniform plexus, we have lymph vessels, it's always present in every way. And please remember this, that the genitofemoral nerve, the genital branch of genitofemoral nerve is present, in plexus of sympathetic nerves is present. In nerves we have plexus of sympathetic nerves also present there. Remains of processus vaginalis, which are used, it was the remnant, it's a remnant, and its remains of processus vaginalis are also present in spermatic cord. So there are 6 structures we saw here. Remember these 6. Covering of the spermatic cord from within outwards follows: internal spermatic fascia, cremasteric fascia, external spermatic fascia. So we know the spermatic cord has the covering. So first of all there will be internal spermatic fascia, which is just anterior layer. Then after that we will have internal cremasteric fascia. Then we will have the external spermatic fascia. So external spermatic fascia will be formed by the extramost layer, that is external oblique aponeurosis. Then cremasteric fascia will be formed by the internal oblique muscle, and the most anterior, that is internal spermatic fascia, it is derived from the fascia transversalis. So it is derived from all these things. External spermatic fascia, external oblique muscle. Cremasteric fascia derived from internal oblique muscle, internal oblique transversus abdominis muscle. So it is both internal oblique and transversus abdominis muscle made up of mucous loops constitute cremasteric muscle. Mechanism of inguinal canal, how inguinal canal is present, how it prevents, what is the mechanism of this inguinal canal? The presence of inguinal canal is cause of weakness in the lower part of anterior abdominal wall. Weakness is compensated by following factors. We know that if there will any canal is present in the anterior abdominal wall, so it will lead to weakness, means any abdominal content can come out through this canal. So if any content will come out through this canal, then it is a point of weakness there. So weakness is compensated by following factors. We have obliquity of inguinal canal. So the inguinal canal is what? Oblique. Two inguinal rings do not lie opposite to each other. Means these inguinal rings are present in such a way that they are not opposite to each other. Means if they will be just opposite to each other, then they would be compressed and the structures would come out. So if they are separated, they are not opposite to each other, then they will compress, then nothing will happen. This canal will be closed. If pressure is increased above, then this canal will be closed and nothing will happen. Two inguinal rings do not lie opposite to each other. Therefore, when intra-abdominal pressure rises, the anterior and posterior wall are approximated. Both the walls will be approximated. This is known as flap wall mechanism. This is very important, flap wall mechanism. So please remember that obliquity mechanism of inguinal canal, because it's a point of weakness, so there's mechanisms which compensate this, and for this we have obliquity in the inguinal canal, and when there is inter-abdominal pressure it rises, the anterior and posterior wall are approximated, and this is called flap wall mechanism. Flap like a flap, they will get closed. So it's called flap wall mechanism. Superficial ring guarded from behind conjoint tendon, reflected part of inguinal ligament. So superficial ring guarded In the superficial ring, we have conjoined tendon and reflected part of inguinal ligament. So it is superficial. This is called superficial ring guarded. Means they will close this. Deep inguinal ring guarded from front internal oblique. So the internal oblique which is present all over there. So they will guard the deep inguinal ring. Superficial is guarded by conjoined tendon, reflected part of inguinal ligament. We have also read here the conjoined tendon, reflected part of inguinal ligament was present in the posterior wall, medial two-third. Medial two-third means here is the superficial inguinal ring, and that is the internal oblique is present in the lateral. So here it is the deep inguinal ring. So we have obliquity of inguinal canal, superficial ring guarded, deep ring guarded, then shutter mechanism of internal oblique muscle. Internal oblique muscle shutter. Muscle has triple relation to inguinal canal. It form anterior, posterior wall and roof of. See, in the internal oblique, where we have learned the internal oblique. In the first of all, we discussed about the anterior wall. In the anterior wall, there was the external oblique muscle, and also there was the conjoined tendon of the internal oblique muscle. Okay, and in the posterior wall we have the internal oblique muscle. In the roof we have shown that it is the external oblique internal oblique muscle. So it is having triple relations with the inguinal canal. So muscle has triple relation to inguinal canal. It forms anterior, posterior wall and roof of canal. So जब ये कॉन्ट्रैक्ट करेगी तो रूफ क्या हो जाएगी, अप्रोक्सीमेट हो जाएगी फ्लोर से. जैसे कि शटर बंद हो रहा है तो जैसे ही वो कॉन्ट्रैक्ट करेगी तो जो रूफ है वो फ्लोर से क्या हो जाएगी, कॉन्ट्रैक्ट हो जाएगी और क्या हो जाएगा, इट विल क्लोज. तो जैसे ही कोई हमारा प्रेशर बढ़ता है तो फिर क्या करेगा, ये कॉन्ट्रैक्ट होगी. जो हमारी इंटरनल ओब्लिक मसल है वो हमारी कॉन्ट्रैक्ट होगी और इसके कॉन्ट्रैक्ट होने से ड्यू टू इट्स कॉन्ट्रैक्शन द रूफ एंड द फ्लोर विल approximate and they will close. Contraction of cremastric ball wall mechanism help spermatic cord to plug superficial inguinal ring. So there is contraction of the cremaster and this is also called ball wall. That was called flap wall mechanism because of the obliquity, and here we have due to contraction of the cremaster we have ball wall mechanism. Spermatic cord to plug superficial inguinal. This superficial inguinal ring can be plugged. This is called ball wall mechanism. Split wall mechanism, contraction of external oblique result in approximation of two crura of superficial inguinal ring. We know in superficial inguinal ring there were two cruras. So due to the contraction of the external oblique result in the approximation of two crura of the superficial inguinal ring. This is called split wall mechanism. We have flap wall mechanism, we have superficial ring guarded, we have deep ring guarded, and we have shutter mechanism for internal oblique muscle, because the roof and the floor that is guarded because it has three relations with it. Then we have contraction of the cremaster ball wall mechanism and split wall mechanism. Contraction of the external oblique result in the approximation of two cruras. Split wall mechanism. This is called ball wall mechanism. It's called slit wall, and it's called flap wall mechanism. Split wall is for the cremastric. It's for the superficial inguinal ring, and the split wall mechanism it's for the two cruras of the superficial. So mainly superficial inguinal ring is monitored here. So superficial inguinal ring we have both in ball wall mechanism and split wall mechanism, and also we have in here superficial ring guarded. This is all about the superficial inguinal ring and deep inguinal ring. So now we have the diagram. So in diagram we firstly have to draw what we have to. This is the medial and this is the lateral side. Firstly we have to draw this outermost layer which will be having the peritoneum, extra peritoneal tissue and all. As we have studied here, we just studied extra peritoneal tissue and parietal peritoneum, everything will be there. Then we will have the external peritoneal connective tissue and peritoneum. This is the fascia transversalis, that is the innermost. Then from here we know that deep and superficial inguinal rings, it will start and it will come down and continue as the spermatic cord. And this one is the aponeurosis of external oblique muscle. This is reflected height of inguinal ligament. This is conjoined tendon. Whole here is the conjoined tendon. This is the tendon of abdominis and internal oblique. These are all the things. In this spermatic cord, we will make the outermost layer, that is outermost layer is external spermatic fascia. Then we have cremastric fascia. Then we have internal spermatic fascia. And in the internal spermatic fascia, we will have this ductus deferens. We will have testicular arteries. We have artery to ductus deferens with sympathetic plexus. We have lymph nodes, and we have this pampaniform plexus of veins. Genital branch of genitofemoral nerve, it is present outside this, it is present outside internal spermatic fascia. In the cremastric fascia, we also have cremastric muscle, and here only the genital branch of genitofemoral nerve is present. And this is the artery of cremaster, and this is nerve which will supply, and ilioinguinal nerve somewhat out of it. So this was all about all these things. Hernia will be discussed here. Hernia is a protrusion of any abdominal content through any of its wall. This is called external hernia. Intestine protrudes into the no entry zone within abdominal cavity itself. This condition is called internal hernia. If the intestine protrudes into the no entry zone within abdominal cavity, within abdominal cavity, if it extends, if it protrudes within abdominal cavity, then this is called internal hernia. And hernia, it consists of sac, content and covering. We will have a sac, we will have some contents, and there will be some layers which will cover this. So this sac, content and covering. Types of hernia: internal, external hernia. Inguinal hernia, protrusion of loop of intestine through intestine wall, is called inguinal hernia. Indirect and direct hernia also we have